Hey guys, it's Medicosis Perfect Status, where medicine makes perfect sense. Let's continue our series called Labs. In the previous videos, we talked about beta-2 microglobulin, methemoglobin, sputum cytology, lactic acid, lactate dehydrogenase. We talked about uric acid in the blood and in the urine. Today, we'll talk about chloride in the blood, and in the next video, we'll talk about chloride in the urine. What is the reference range for serum chloride? Well, it depends on your age. For most adults, it's 98 to 106 milli equivalent per liter or millimole per liter. The millimole per liter is the standard international unit. In children, it varies between 90 and 110. In a newborn, 96 to 106. In premature infants, 95 to 110. My way of remembering serum chloride is just remembering 104. That's the average. Please watch the videos in this playlist in order. In today's video, we're talking about chloride in the blood. In the next video, we're talking about chloride in the urine. You gotta watch both for maximum understanding. Let's start with some basic chemistry because doctors suck at it. Chlorine versus chloride. Chlorine is Cl2. Chloride is a negative anion, Cl negative. What's the technical term for this? Diatomic molecule, because it's a molecule made of two chlorides. And since the two chlorides are identical, it's mononuclear because it's just only one type. The technical name for this is a negative ion or anion, which will be attracted to the anode, which is the positive pole or the positive electrode. Does this have any charges? No, therefore it's not going to attract sodium or be attracted to sodium. But look at this, does it have a charge? Absolutely. Therefore, it is attracted to sodium. Chlorine is toxic. This is what you use to clean your pool. It is toxic to the bacteria. You will not find chlorine in the human body. You'll only find chloride, the ionized one. So if my doctor said to me, quote, "Medicosis, I'm worried about your serum chlorine level. It is 92. I will use my patellar tendon reflex, aka knee-jerk reaction, to kick that doctor in the testicles. Metaphorically speaking, because there is no chlorine in my body. There is only chloride. Moreover, what was the chlorine number you said? 92. Well, still, boo-hoo. No big deal. You only care about hypochloremia when it drops below 80. But the chart here says that the normal reference range... Who cares? Use your brain. I don't have any symptoms and all of my other labs are fine. So chances are this chloride level is not significant. Chloride is an electrolyte. What does that mean? Electro means electrical, light means decomposition, which means these are molecules that can be decomposed into positive charges and negative charges. Look at that. That's an anion, which means it's an electrolyte. Separation via electricity. To remember the serum chloride level, just remember my rule of fours. What's the normal sodium in the blood? 140. How about chloride? Just 104. Bicarbonate, 24. pH 7.4, potassium, phosphate, albumin around 4. How about the thyroid stimulating hormone TSH 0.4 until 4? This is to just memorize the labs. If you want to understand the clinical significance, just remember sodium. And remember that chloride is always following sodium. Like father, like son. Whatever happens to sodium is usually the same thing that's happening to chloride. Since it's a negative charge, it has an important role in your body, which is to maintain electroneutrality. If you add a positive ion to the body, you gotta add another negative ion to the body to balance it out. Normal serum chloride level for adults ranges between 98 to 106 milli equivalents per liter or millimole per liter, and this is le système international d'unité, the international system of units. It's the millimole per liter. Don't worry too much about these numbers, just memorize 104. But how about the urine chloride? The urine chloride has a wider range, and it's usually higher than the serum chloride. Because remember that your metabolism secretes acid. Who's gonna take care of these acids and get rid of them? The kidney will. When the kidney gets rid of the acid, remember the titration of the ammonia story. You get NH3 plus the H, which is the proton, the acid, lump them together. Now you have NH4 positive. NH4 positive will attract the negative chloride. Before you know it, you have NH4Cl and then you dump that compound into the urine. That's why we have tons of chloride in the urine, and that's normal. If you want to learn more about this ammonium story and the titratable acidity, download my kidney physiology course at medicosisperfectionalis.com. Chloride is an anion, most abundant in the extracellular fluid or the intracellular fluid. Extracellular fluid. It's more abundant outside the cell than inside. Remember when I told you before, anything that's inside the cell starts with P. Potassium, proteins, phosphate, magnesium, which is in the supernova. All of these P's are more abundant inside the cell. Anything else is more abundant outside, including chloride. And since sodium is more abundant outside the cell, chloride gotta follow sodium. Why is sodium more abundant outside the cell and potassium more abundant inside the cell? You should say thank you to your sodium-potassium pump, which pumps sodium to the outside and potassium to the inside. And then chloride is gonna follow sodium to the outside. Chloride, not chlorine, is the major anion in the extracellular fluid. Normal serum chloride is around 104 milliequivalent per liter or millimoles per liter. Chloride level usually follows sodium, like father, like son. Chloride follows sodium. Do we have some exceptions? Yes, we do have some exceptions in the acid-base disturbances, in which case chloride is usually related not to sodium but to bicarbonate. And if you studied your physiology carefully, you will recall the chloride shift phenomenon, in which chloride goes against, not sodium here, but bicarbonate. Bicarbonate in, chloride out, and vice versa. Bicarbonate out, chloride in. Negative for negative. Hashtag electroneutrality. Chloride is important in metabolism and acid-base balance. Chloride is excreted by your kidney. But if I have kidney failure, what's going to happen? Chloride will pile up in the blood, hyperchloremia. It will exceed the normal reference range. So it will be above 106, but that's just on paper. Clinically speaking, for us to worry about hyperchloremia, it's gotta exceed 115 milliequivalents per liter. Do you remember how GABA works? Do you remember benzodiazepines, barbiturates, alcohol? They work by stimulating the GABA, and the GABA works with chloride. Once chloride, which is negative, enters your neuron, now you have a negative inside your neuron, which causes not depolarization, but the opposite. Hyperpolarization, not activation, the opposite. Inactivation of your neurons. That's why these are what? Sedatives and hypnotics. They will calm down your soul, but they can kill you. Especially these two right here. It's the dose that makes the poison. Do you remember tetany? Oh yeah, we have muscle spasms, carpal spasms, pedal spasms, laryngeal spasms, positive chauvistic and Rousseau. Yeah, what's the cause? Usually hypocalcemia. Yes, but don't forget hypomagnesemia and also hypochloremia as causes for tetany. You'll need to open your physiology book and review the chloride shift phenomena because it's very important. Remember that the normal serum chloride concentration is how much? Around 104 milliequivalent per liter. That's a concentration, which means it's the number or mass of particles that we have over the volume of fluid. But what if I'm dehydrated? What do you think is going to happen to the volume? The volume goes down. Therefore, what's going to happen to the entire ratio? It will go up, and your serum chloride concentration will go up. Hashtag hyperchloremia. So one of the common causes of hyperchloremia is dehydration. It's also a common cause of hypernatremia, but not hyperkalemia for reasons that we'll discuss later. And for the gazillionth time, I always remind you not to confuse dehydration with volume depletion. Dehydration is loss of just water. Volume depletion is loss of water and electrolytes. This patient needs just water, but this patient needs water and electrolytes. Next, let's take it to the next level. Let's say that I have tons of carbon dioxide in the blood. Carbon dioxide plus water equals carbonic acid. Oh, that's an acid. So increased protons in the serum means that someone has to buffer these excessive protons in the blood. Who's gonna buffer the excessive protons in the blood? Bicarbonate. The base will buffer the acid. So the base has to leave the cell, could be red blood cell or any other cell by the way. Bicarb will leave. As bicarbonate leaves, it will neutralize and buffer the acidity in the blood. However, when a negative leaves the cell, to maintain electroneutrality, another negative gotta go inside the cell. And this is Mr. Chloride. And that's why, in most cases, whenever you see increased bicarbonate in the plasma, chloride will go down. and vice versa. Cause medicine makes so much sense once you understand what the flip you're talking about. Next, causes of hypochloremia versus hyperchloremia. This is just based on the reference range. Let's make it clinical. We do care about hypochloremia when it's below 80, and we will not care about hyperchloremia until it exceeds 115, provided that everything else in the patient is fine. Causes of hypochloremia. Don't forget that HCl is in your stomach, right? The stomach is part of the gastrointestinal system. So anything that makes me lose gastrointestinal content will make me lose HCl and therefore lose the Cl and therefore develop hypochloremia, e.g. vomiting, diarrhea, gastric suction. Peptic ulcer disease, tons of acid, and increasing the risk of irritation, vomiting, and there is association between peptic ulcer disease and COPD. Moreover, COPD causes what? Respiratory acidosis for the most part. Increased protons in the blood means that bicarbonate has to leave the red blood cell or any cell and go to the outside. Who's gonna go to the inside now? Chloride, leaving less chloride in the blood. Hypochloremia. SiADH, too much ADH dilutes my plasma. The denominator has been diluted, it goes up, but the entire ratio will go down. Hypochloremia. Chloride has been diluted. How about CHF, congestive heart failure? It causes volume overload. Too much fluid, chloride gets diluted. Hypochloremia. Third degree burn. Everything is oozing through my burnt skin, such as sodium, and chloride follows sodium, hypochloremia. And then water is going to follow both. It's called osmosis. The patient is volume depleted. Don't say the patient is dehydrated, or I'll smack your gluteus maximus, rhetorically speaking. Moreover, any condition that causes loss of sodium in the urine, natriuresis, will also cause loss of chloride in the urine because chloride follows sodium. One example is salt-losing nephritis. Many patients with kidney disease could be divided into two groups, salt-losing versus salt-retaining. And of course, there are exceptions. How about COPD? Respiratory acidosis, carbon dioxide piles up, increased protons in the serum, bicarbonate will leave the cell to buffer the acid, chloride will go into the cell, causing hypochloremia. So another cause of hypochloremia is any respiratory acidosis. Next, I just told you that when bicarbonate is increasing in the blood, chloride is leaving the blood and going into the cell. So I get hypochloremia with metabolic alkalosis. Medications that can lead to hypochloremia. Aldosterone. Now this might sound counterintuitive because people say aldosterone will help me reabsorb sodium and water, and chloride is going to follow sodium, therefore I'll get hyperchloremia. Yes, it can happen, but in most cases, aldosterone does the opposite. I don't get it. Don't forget that aldosterone not only reabsorbs salt and water, but it also excretes potassium and hydrogen. When you excrete hydrogen, you develop metabolic alkalosis. Metabolic alkalosis causes hypochloremia because when you have an abundance of bicarbonate in the blood, it means the chloride has to leave the blood and go into the cell. Or in this case, to the urine. Why is that? Because aldosterone makes me excrete the protons in the urine. But the protons are very acidic, they can burn the tubule. So I gotta buffer that. How do you buffer them? It's the ammonium story, the titratable acidity. NH3 plus H equals NH4 plus. NH4 plus Cl minus equals ammonium chloride, which is less acidic than the protons alone. It's actually slightly alkaline to protect the tubule from the acidity, so chloride in this case is being lost in the urine. Any condition that traces bicarbonate in the serum will lower chloride in the serum. Cortisone, same thing. Cortisone, when given exogenously, has a mineralocorticoid effect. Can lead to metabolic alkalosis before you know it, hypochloremia. Loop and thiazide diuretics make you lose tons of sodium in the urine, which means chloride will follow, so they cause hypochloremia. Next, causes of hyperchloremia, dehydration. Yes, when the L goes down, the entire ratio goes up, which means hyperchloremic. We just talked about this 5 minutes ago. Hyperparathyroidism. I don't know exactly why, however, I have a hypothesis. I know that alkalosis is anti-ionized calcium. The more alkalosis you have, the lower your ionized calcium in the blood. Conversely, the more ionized calcium that I have in the blood, the less alkalosis. So this land is the opposite of this land. This is just how I think about it. If you have a better explanation, please let me know. Cushing, mineralocorticoid activity, It can reabsorb sodium and chloride. However, Cushing can act as cortisone, of course, developing alkalosis and causing hypochloremia. So it can go either way. Your body is more complex than you think. Next, excessive saline infusion. Why? Because saline is basically salt and water. Salt. I'm giving the patient more chloride. Of course, the patient will develop hyperchloremia. No kidding. Any condition that causes normal anion gap metabolic acidosis, we'll talk about that later. One example is renal tubular acidosis, kidney disease, because normally the kidney should excrete chloride. But if the kidney is sick, my kidney is toast, cannot excrete chloride, I get hyperchloremia. Don't forget that severe hypertension, preeclampsia, eclampsia, all of them can lead to kidney disease, which means all of them can lead to hyperchloremia, a fact that many obstetricians are unaware of. I have no idea why this patient is having hyperchloremia. Maybe I should refer them to nephrology. Doofus, get your head out of your sphincter and read a book. But I can book a free consultation on this modern iPad. Okay, and how much time are you going to waste until the nephrologist tells you that this is because of the kidney disease, because of the eclampsia, and once you treat that, it should go away? You should know this already. Time is not free, especially when the patient is sick. Please, my dearest students, study hard, master your craft, and don't be another doofus with a stethoscope. I love you. If respiratory acidosis causes hypochloremia, then reverse it. Respiratory alkalosis causes hyperchloremia for the exact opposite reason. Again, it's about the chloride shift. Medications. If loop and thiazide diuretics cause hypochloremia, let me surprise you and tell you that the other two diuretics, acetazolamide and spironolactone, cause hyperchloremia. If you want to know why acetazolamide causes hyperchloremia, watch my video on acetazolamide and another video on the acute mountain sickness. Spironolactone is easy to explain. It's anti-aldosterone. If aldosterone causes hypo, then the anti-aldosterone causes hyper. It's common sense. Next, if the doctor is giving me ammonium chloride, of course my chloride will go up. No kidding. How about this hydrochlorothiazide medication? Oh, only this one raises the chloride. But if a thiazide does not have chloride in it, then it will cause hypochloremia. So you gotta be very careful. Fluids, electrolytes, and acid-base balances are subtle indeed. And just like Cushing can lead to hyperchloremia, cortisone can lead to hyperchloremia as well. But again, be careful because the same cortisone can lead to the opposite, alkalosis, which triggers hypochloremia. Clinically speaking, a patient who has hypochloremia can develop tetany. Why? Because many cases of hypochloremia are associated with alkalosis. The more bicarbonate you have in the blood, the less chloride you have in the blood. And if you have watched my course on electrolytes, I've told you that alkalosis adds negative charges to albumin. So albumin becomes more negative, attracts more calcium from the blood. So the ionized calcium left in your blood goes down. And this is the physiologically active calcium, which means this will lead to symptoms of tetany. And I've told you before, calcium is contra-excitability. When the ionized calcium in the blood goes down, nerve excitability goes up. Hashtag carpal spasm, pedal spasm, laryngospasms, hyperexcitability of nerves. Look at that, hyperexcitability of nerves. And if nerves are hyperexcitable, they will excite the muscles too. Because who talks to the muscle? The nerve does. It's called the neuromuscular junction. Many of these patients have COPD, shallow breathing. Also, the hyperexcitability can lead to shallow breathing. Chloride follows sodium, which means if chloride is low, sodium is probably low. And if sodium and chloride is low, it means that the water is leaving the body, hypotension. Hyperchloremia can lead to weakness, lethargy, and the opposite, deep breathing. More notes. COPD can lead to respiratory acidosis. We know that because of the retention of carbon dioxide. It can also lead to hypochloremia. And any case of respiratory acidosis can present with hypochloremia. We just talked about that. Anything that makes me lose gastrointestinal fluid will make me lose HCl. So when you lose the H, you get alkalosis. When you lose the Cl, you get hypochloremia, such as vomiting, diarrhea, etc. Hyperparathyroidism causes, number 1, hypercalcemia, 2, hypophosphatemia, 3, hypernatremia, and 4, hyperchloremia. Chloride follows sodium. Do you remember the high anion gap metabolic acidosis and the normal anion gap metabolic acidosis? I've told you before that in high anion gap metabolic acidosis, the anion gap is high. However, the serum chloride is normal. Conversely, In normal anion gap metabolic acidosis, the anion gap is normal, but the serum chloride is high. It's hyperchloremic. So, any cause of NAGMA is associated with hyperchloremia, such as renal tubular acidosis, RTA. The way I remember this is that I think of the anion gap and chloride as two things that cannot be elevated together at the same time. If your anion gap is elevated, it means your chloride is not elevated. But if your anion gap is normal, your chloride will be elevated. If you want to know the exact mechanisms and the explanations behind why HAGMA is normochloremic and why NAGMA is hyperchloremic, I've made 2 videos about these topics in my playlist titled Ever Wonder Why? We just talked about the medications that disrupt serum chloride level, and many of them disrupt sodium too, like father, like son. Here are some medications that can lead to hyponatremia and some medications that can lead to hypernatremia. All of these doofuses can affect chloride levels. Medicosis, my patient is having hypochloremia, low chloride level in the blood. Is this due to sodium loss because chloride follows sodium? Or is this something hormonal, like hyperaldosteronism? Well, to know the difference, order urine chloride level. And this will be the topic of the next video titled Urine Chloride. You'll find it in this labs playlist. Some pearls for the pros. In the plasma, if I have metabolic alkalosis, more bicarbonate, less chloride in the plasma. If I have NAGMA, bicarbonate is down. Who's gonna take its place? Chloride. Hyperchloremia. In HAGMA, the anion gap is high, but the serum chloride is normal. Because here, bicarbonate is low. Who's gonna take its place? It's not the chloride, it's the unmeasured anion. Maybe it's methanol, like formic acid particles. Maybe it's ethylene glycol metabolites. Maybe it's the uremia. Maybe it's the lactic acid. Another electrolyte is being added, and therefore there is no need for chloride to change. Again, you can learn more about these two by referring to my playlist, Ever Wonder Why? Respiratory acidosis. This is my COPD patient. They developed hypochloremia because the more acid you have, the more protons. Bicarbonate's gotta leave the cell to buffer the acid, and chloride's gotta enter the cell, leaving less chloride in the blood. Respiratory alkalosis is the opposite. Who else is gonna teach you like this? Your woke professor with his PowerPoint? Give me a break. If you want to learn more about metabolic acidosis, HAGMA versus NAGMA, and metabolic alkalosis, saline responsive versus saline resistant, if you want to learn about the base excess and the base deficit, the osmolar gap and the anion gap, download my acid-base imbalance course, the best on the planet, at medicosisperfectionalis.com. We talked about chloride today. If you want to learn more about sodium, how about potassium, magnesium, my beloved phosphate, etc., download my electrolytes course at medicosisperfectionalis.com. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.